Welcome to Make Me Data Literate, the podcast that makes data intelligible from the Australian Data Science Education Institute. We're on a mission to make the whole world data literate. I'm your host, Dr. Linda McIver, and every week I'll interview someone with a wild and wonderful relationship to data. Let's see what we can find out. I am super excited to have as my guest today Professor Adrian Esterman, an epidemiologist and biostatistician who has, among other things, worked with the South Australian Health Department, the World Health Organization, and now the University of South Australia. Professor Esterman has also been an incredibly important public source of easy-to-understand information on the COVID-19 pandemic. Thank you so much for coming on my podcast.
Oh, you're most welcome, Linda.
Firstly, can you explain what it means to be a biostatistician and an epidemiologist?
I'll certainly have a go anyway.
The nutshell version.
Okay, so statistics is a sort of branch of mathematics, sort of handling sort of data, and biostatistics is basically statistics applied to health and medicine. And so biostatisticians tend to get their qualifications in schools of public health rather than in departments of mathematics. Um, Epidemiology, I'm sure most people have heard of epidemiologists these days, but it's the branch of science or branch of medicine that actually handles diseases of populations. So, what ones are there? What causes them? Who gets them? How can we control and prevent them? And again, epidemiologists are usually trained in schools of public health. And so many epidemiologists know a bit about biostatistics. All biostatisticians know a bit about epidemiology. And I've got a master's degree in biostatistics and a PhD in epidemiology. So I've got a foot firmly in each camp.
That's awesome. I think this is the first kind of time in history when many of us have a favorite epidemiologist.
Yes. I think in 2020, there were two sort of senior editors sort of arguing about who was their favorite one, and I got nominated. So I was quite pleased with that.
Well, I've been following all your Twitter updates and conversation articles, and yeah, definitely up there for me as well. It's been really nice to see the science explained so clearly and the things that people care about kind of put in intelligible terms. So I guess that brings us to our first question, which is, what do you wish everyone knew about data?
About data, oh dear. Well, it'd be nice if everyone was numerate. Um, what we're finding is that the greater and greater proportion of our students, both undergraduate and postgraduate, can't spell and can't count, which is a bit of a shame.
Wow, even at
And
postgrad level.
yeah, says a lot about our education system.
That's
So, so,
disturbing.
look, one of the big problems with experts, or whether economic experts or any other sort of science expert, is that they have a lot of trouble sort of bringing their conversation down to the level of the general public. They can't help it. It's what you get taught. You get taught your own language, and then you speak it. And one of the glorious things about the master's degree I did was that there are about 30 students. This is at the London School of Hygiene and Tropical Medicine. So 15 of us were statisticians, and 15 were doctors. And so the statisticians learned a lot about biostatistics or statistics applied to medicine, but we also did almost a whole first year of medical degree. So we did physiology, anatomy, pathology, microbiology, and it was just fantastic because by the time we got our master's degrees, we could really communicate well with doctors, because that's a big problem with doctors trying to communicate with biostatisticians. And that's always stood me in good stead in the sense that it made it easier for me to actually communicate sort of findings. And working in WHO was a similar thing because I was working with people who spoke, a dozen different languages. So next door to me, I had someone who was an Arab. There were lots of French there. And you really had to learn to communicate well and to write very clear and simple English. So all those things has actually helped in the current situation. And by and large, I'm neither a biostatistician or epidemiologist these days. I'm more of a science communicator because that's what I spend half my life doing.
I've seen you become more and more active on Twitter as well, which I think has been really valuable. And I heard a talk from the founder of COVID19data.com.au saying that she was using a lot of your stuff, and It's really nice to see it getting out there and making sense to people. Do you feel like people's understanding of data has improved because of the pandemic?
Yeah, I mean, there aren't many good things that come from out of a pandemic, but I think one of them is that people have now heard of epidemiologists, so I think that's got to be a good thing. But yeah, I think people's understanding of data has definitely improved. They're seeing more graphs and charts, etc. But still, there's an awful lot of understanding and misinformation on the internet. Uh, People deliberately sort of taking parts of a table, which I'd look at it and think, what on earth's that about? And they've done it deliberately to actually falsify the figures. So unfortunately, that's absolutely rife out there with all this stuff about QAnon and conspiracy theories, and it's basically people either falsifying figures or taking existing ones and cherry picking bits that they like and not looking at bits they don't like.
Do you have I guess favorite is the wrong word, a most appalling example of the misuse of data? Is there one that stands out as the worst thing, or is it just so rife that you can't even choose?
Well, if you talk about the misuse of data, there's been at least two cases of total fraudulent scientific papers, people having made up their own data. And these two papers were about ivermectin. So ivermectin is a drug that's basically used mainly for veterinary use. It's an antiparasitic, but we also use it in humans. So we use it for things like scabies and some worm diseases. But the point is that it's been touted as a sort of a wonderful cure for COVID-19. And the fact of the matter is it simply doesn't work for COVID-19. And yet thousands of people around the world are taking it. And recent sort of what we call a systematic review, which looks at dozens of different studies, found that it worked. But it turned out that two of the papers, which they based most of their conclusions on, were totally false. People have made the data up. So that's what
Do you,
we're having to contend with now.
how did they figure out that the data was made up? How did that come out? Do you know?
Well, actually, there are detectives out there, let's say data sleuths, who look for these things. So, for
That's
example,
fabulous.
if you've got a sort of column of data, let's just say it's to one decimal point. So you've got sort of 10.1, 3.7. You expect the last digits, the digit after the decimal point, to actually have a certain distribution. Like you don't expect all threes, that would be
Mm.
extremely rare. So they actually analyze the data in papers and look for very weird results. When they find it, they then dig further and discover that the whole thing's made up.
It's horrific that that you can wind up with public policy based on depending on those kinds of papers and then find out that they're not real. Do you have any advice um, for people looking at data themselves, in the media, particularly certain sections of the media that like to misrepresent things, not naming any names?
Well, look,
How do people spot that?
the key one is with graphs or charts. Okay, they should always start at zero. So often they'll start at much higher than zero, and that just changes what the graph looks like. It makes it look much steeper than it is. And that's one that's commonly used to mislead people.
I use that example in my teacher workshops, and even with teachers of maths and digital technologies, I'll show them, a data set that's sort of clustered around 100 and with a zero at the scale or with a 90 at the bottom of the scale, and they're just astounded at how different it looks. I,
Exactly.
I do think we need to emphasize that more. It's tricky to get that across sometimes. What
But
are some of the
one
worst?
sorry, one of the Linda, one of the biggest things that's extremely difficult to get over to the general population is risk, the concept of risk.
Yeah.
So, for example, if you catch COVID-19, what's the risk you'll get seriously ill? And it's not an easy concept. Um, I try and tell it to people like you've got more chance of being struck and killed by lightning, which people can understand sort of how rare that is. But
Yeah.
nonetheless, when they talk about, oh, there's an incidence rate of this much, and the case fatality rate of this much, people's eyes just glaze over.
Yeah, some other friends of mine have talked about the challenge with particularly Karen Lamb, who's also a biostatistician, talks about the people's understanding of relative risk and change in risk versus absolute risk, and it really is a complicated topic. Do you think we need to get better at communicating that?
Oh, it's really difficult. There was a situation a few years ago where there was this 1,000 women study which looked at women who are on the pill and the risk of breast cancer. And it's a huge study from the United States, and the authors concluded that women who are on the pill were three times the risk of breast cancer. It might have been heart disease, actually. I can't remember. Anyway, they were at three times the risk of this adverse outcome. But
Mm.
what it turned out was that the risk was incredibly small. So three times 0.000001 is 0.00003. You've still got Buckley's chance of getting it. So,
Yeah, but
and
three
this
times sounds scary.
and the results of this paper went all around the world. Okay. And so even scientists get it wrong. So what's the hope is there for the general population?
Yeah, it's a tough one, that one, and especially when policies need to be based around that, especially in the circumstances we find ourselves in, in the middle of a pandemic. I was watching a video of yours this morning where you talked about your wish for an Australian CDC that was apolitical. Do you think it's possible for science to be apolitical these days?
It's more and more difficult. So to give you an example, if you look at our chief public health officers around Australia, even though they're all medically qualified, they're all turning out to be politicians. They have to
Mm,
be,
mm,
because they're public servants. They have to listen to their masters, and not put their masters at risk of any political damage. And so they end up becoming no longer public health experts. They end up becoming, political animals, which is a great
yeah.
shame. So yeah, it is extremely difficult. In America, of course, we've got CDC Atlanta, which is and was the most respected sort of public health organization in the world. What happened there was Donald Trump put all his own appointees in and started getting them to change things, which was absolutely shocking, and it just shocked all of us. So we can't have that happening. So when we do, and hopefully we do establish a CDC, it has to be totally separate from government. Government can't have any say in it, and it has to have a budget that's fixed, um, and not touchable by the government. And I think it's doable. I mean, it's tricky, but I think it's doable. And then it becomes totally independent of government.
Yeah. Governments don't like things that are independent, though.
No, they hate it.
Especially at the moment. Coming back to graphs for a minute, when you see a graph in the media, apart from looking for a zero on the scale, what else do you look for to kind of
Well,
gauge its
they've got to be
validity?
They've got to be labelled properly. You've got to be able to see what's on, the x-axis and the y-axis. The thing about graphs is that uh, they have to be very easy to read at first glance.
Mm.
If it takes you 10 minutes of staring at the thing, trying to work out where things are and what the axes are, then it's a waste of time. So graphs are extremely helpful, but they have to be really well labeled so that anyone can understand, what's on the x-axis and what's on the y-axis. And often that doesn't happen.
Yeah, I think that point of anyone being able to understand it is crucial. Early on in particular in the pandemic, a lot of graphs were being published in, very reputable sources like the ABC that had log scales, which is perfectly valid, perfectly scientifically accurate. But I think the percentage of the population that understands how to read a log graph is perhaps not what we'd like it to be.
Look, if someone said to me, Adrian, what percentage of your undergraduate students understand what a natural logarithm is? I could probably count it on one hand. I'm not sure what's happened to the state of mathematics in Australia, but it seems to have gone downhill.
Do you think it's an Australian thing or a worldwide thing?
Oh, it's probably a worldwide thing. I shouldn't count Australia. It's probably over the whole world. But I mean, what's happening at the moment is that there are many, many Asian countries like Taiwan, um, Singapore, where their school kids rank well above us in just about every scale that they measure.
Mm.
So you know, I'm not sure what's happened to Australian education system, but it's really well behind other Asian countries.
Yeah, it's a problem. And it's particularly a problem when you wind up with a political class who don't have that understanding of data and who aren't able to make evidence-based decisions, or at least that's the way it seems from this angle. Um, we've talked about some sort of deliberate misuses of data. What are the worst data mistakes that you've seen? Just accidental.
Let me just say that everyone, including myself, makes mistakes. Okay, so it's just a fact of life. When you deal with so much data, it's so easy to switch two figures over, or someone distracts you. And um, I get taken to task on my Twitter feed, for making mistakes. And if someone finds I've made a mistake, I actually thank them. I
Yeah.
can say, "Thank you so much." I don't have anyone looking over my shoulder, double checking my figures. And for me, it's really helpful that someone finds a mistake I've made, and then immediately delete the tweet and rectify it. So I think that everyone, including you, believe it or not, makes mistakes. And
Oh, I
and
know it.
and the key is to understand that everyone does make mistakes. Try and get systems in place that double check things. In my case, I can't because I work on my own, so I haven't got anyone double checking whatever I do. And
Yeah.
try and put systems in place that can double check things, so that if something doesn't make sense, you see it immediately. But if you do make a mistake, fess up, change it, and correct it. And I think that's the real key thing. Everyone makes mistakes. If you've made one, hand over heart. I've made a mistake. Sorry, I'm correcting it now, and that's the best thing you can do.
I think that point of thanking people and actually even rewarding people for finding errors is really important. I used to, my first class with a new group of students, I'd always say, "Do you trust me?" And they were, very well brought up, polite kids, and they'd say, "Yes, of course we do." And I'd say, "Well, don't." And they practically fall off their chairs. But I wanted them to double check and to challenge and to ask critical questions. And if they get into the habit of just taking, sitting down and drinking the gospel, then it doesn't bode well for their critical thinking, and it doesn't, means no one's going to challenge me on my mistakes, which you know I make a lot of those, and we all do, as you say. Do you think how do we differentiate between asking critical questions, being rational skeptics, and being QAnoners?
Well, let me just move over and put my epidemiology hat on. And that there's basically a group of people who aren't vaccinated yet. I'm not talking about young kids now, but I'm talking about a group of adults who still aren't vaccinated. And they fall into two groups. There's the group who are really concerned about the safety of vaccines, and could be persuaded to get vaccinated if you had time to sit down with them and explain what we know about the safety of the vaccines, what we know about the efficacy of the vaccines. And one of the problems there is that we haven't had really good messaging from different governments explaining to people why it's so important and how safe they are. That all seems to be missing, gone
Mm,
missing in action. But there's also a core of true believers. These are the real anti vaxxers. And you can put evidence under their noses till the cows come home. And the more evidence you give them, the less they believe you.
yeah.
And there's nothing you can do with true believers. Okay? There really isn't. You're just wasting your time even trying to talk to them. So I think that's the current situation. Those are the ones who are going to get sick. Those are the ones who are going to get very sick. And there's lots of stories of people on their deathbed from COVID-19 saying, but COVID-19 doesn't exist. How can I be dying from it? But I mean, that's the world we're living in. Sorry, I should have put my phone on mute.
That's all right. It's an easy mistake to make. I think we'll leave it in since we're talking about mistakes.
Exactly.
Um, do you feel like the proportion of those true believers has changed over the pandemic? You've been in epidemiology for a while. Have you seen a
I
shift in
think
that?
certainly we've seen this huge group of people, especially in the USA, but now that they've now sort of migrated to Australia and lots of other countries now, who believe in these just the most amazing conspiracy theories. Like all of our politicians belong to a satanic pediatric pedophile sect. All this sort of thing.
Yeah.
It's just gone beyond the bounds now. We've got almost every state in America now banning abortion. And
Oh, yeah.
it's beyond the pale. It's starting to get very silly.
I saw some states have banned abortion in the case of ectopic pregnancies, where not only is it not possible for that pregnancy to be viable to term, but it will almost certainly kill the mother if the pregnancy is allowed to go ahead. And I can't understand how they can be making those decisions.
Because these are the true believers I was telling you about. Except this
Uh,
case, it's religion, and I mean, I'm sort of agnostic. I don't really care about religion. If people want to believe in it, that's fair enough, as long as it doesn't affect me. But
mm,
unfortunately, it does affect people.
yeah.
These people are basically uh, disenfranchising millions of women and girls across the world, and unfortunately, there's not much we can do about it. And it's becoming more and more radical in America, unfortunately.
Yeah, it does seem to be getting a lot more extreme, and we're seeing trans kids being thrown under the same bus as women needing abortions. It's horrific.
You shake your head, but it could happen here, you know.
Oh, it is. It is happening here. It's just a question of how bad it gets and how bad we let it get, I guess. Um, One of the things that I do with the project at the Australian Data Science Education Institute is I try to make sure that kids do a lot of projects where there isn't a right answer. And basically that just means using a real data set, because as soon as you use a real data set, that's you're trying to solve a real problem. There's no right or wrong answer. There's just, how well does it work? Where does it fall down? Um, do you think that that kind of uncertainty, that not being able to look the answer up in the back of the textbook, is something that's missing in terms of the experience of your students and the general public?
Well, I don't teach, so I don't. I've got lots of PhD students, but we tend to call them PhD candidates rather than students. Uh, Subtle difference. Um, but look, the whole thing about statistics and probability theory, which is what statistics is based on, is that everything is uncertain.
Mm,
Okay, we can never say something is true. Because that we can't, because we don't know it's true. We can say there's a high degree of confidence that it's true. And it's the same in law. The balance of probability is that he committed murder. But you can't actually say it's certain because you never know. And this is why we run clinical trials. We run clinical trials to try and get an answer. But that answer has got a lot of uncertainty about it. So, I think it's good that we teach that things are uncertain, and we try and generate evidence that tries to at least put bounds around that uncertainty.
and in the world of population health, how do you balance that human desire for, tell me, is this the right thing to do? Tell me, is it safe? Tell me, will I die? All those kinds of questions. How do you balance that need for certainty with that with the fact that certainty just doesn't exist?
Well, that is the whole concept of risk, you see. If
Mm,
someone says to me, is it safe if I have this vaccine? I can say, yes, it is safe, but you could still die from taking
yeah.
it. Okay, it might be a 1 in 1 million chance or a 1 in 3 million chance. In fact, it's even lower than that still. But never mind.
Mm,
But I can't say it's not going to affect you and you're not going to get sick from taking the vaccine, because it happens in some people. It's just incredibly rare. So I
yeah.
could say to someone, the chance of you getting really sick from being vaccinated is actually more rare than you could be dying from being hit by lightning, which is
Yeah.
true. Okay, because people don't understand that's actually fairly common. People get hit by lightning. You know, so so it's extremely difficult trying to get these concepts over to people.
Yeah.
But I do say, if someone says to me, "Are vaccines safe?" I do say yes,
Yeah.
but then I have to qualify that and say, "But." Okay, and the same thing goes with doctors. Okay, when they're going to do a procedure, they'll say to you, like, there's a 1 in 100,000 chance you're going to die from the anaesthetic.
Mm.
Then they go through a list of about 100 other things that could possibly go wrong,
Yes.
because they have to now. They have to now. It's called consent. Okay,
Yeah.
but nonetheless, these things are incredibly rare, and it is a very difficult concept to bring out.
It is. I remember when we were having all of the fear mongering around the AstraZeneca vaccine. I looked up the relative risks of different things, and um, ibuprofen. You've got a much higher chance of dying from taking a Nurofen than you do from the AstraZeneca vaccine, and that just blew my mind, because we don't think of things like Nurofen as having risk associated because they're so common. It's we've kind of I guess, adjusted to this is something that's part of our lives, and it's useful.
In fact, Nurofen is quite nasty.
Mm,
It can excuse me. It can actually damage the lining of your stomach and cause gastric ulcers. So, look, there's not a single thing in the world that you put into your body that hasn't got some danger attached to it. You can die from drinking too much water.
yeah. Yeah, it's really hard to get the idea across when we're of the risk in everyday life. The risk of a car accident is much, much higher, but we're not going to give up driving or being passengers in cars because it's a fundamental part of life.
And this is what's happening now with the epidemic.
Hmm.
People will have to judge their own risk. So I'm older. I've got a health condition that dampens down my immune system. So I will be wearing a mask every time I go out, which
Yeah,
I do. Other people, young, fit, and healthy, if they don't wear a mask, it's not a big deal.
yeah,
If they catch COVID-19, chances are it'll be a mild infection. So everyone will now have to look at themselves and say, what risk am I willing to tolerate? What should I do to try and, dampen down that risk? And to a certain extent, this is what the government's aiming for. All state and territory governments, federal government, they're aiming for people to take their own protection, measure their own risk, and take their own protection because they're taking off all the mandates that they had. So in South Australia, for example, our face mask mandate is coming off on the 15th of April. That's next week.
hmm,
That means that anyone who's vulnerable will simply have to protect themselves rather than the government protecting us. And you might think that's a good idea. And in a certain extent, it is. But in that case, why do we insist people wear seatbelts?
yeah.
Why do we insist that people don't drive when they're under the influence?
I feel like there could have been a middle ground between total lockdown and no safety at all. My 15-year-old got COVID last week because there's no masking in the classroom, and it has just run rampant through the schools. I think most of the kids in my child's school have had it or have it now, and I don't think that was necessary. They could have worn masks. It's such a small thing to do.
It is. And so my only reservation about the lifting of different mandates or public health measures is I would have preferred it if we retained face masks.
Hmm,
It's the one thing that we know works extremely well,
hmm,
and it really does help protect vulnerable people. So people like me, I'm getting a bit wary about going out shopping now.
yeah.
Well, not yet, but when they take off the face mask mandate. The good news is that people living in Adelaide are very sensible, and most of them can still keep wearing face masks no matter what the government says. So in
I hope
that
so.
in that sense,
There's a lot less face masks in Melbourne than I would like to see since they lifted the mandate here. I think that was a mistake.
but you see, our new premier Peter Malinauskas was doing a photo op yesterday in one of our hospitals and saying, "Look, we're opening up 200 new beds to cater for all the new COVID cases we're getting." Then he's lifting face masks.
Ugh,
Well, if he didn't lift face masks, he wouldn't have to open up 200 new beds. I mean, go figure.
yeah, it's tricky when you see the political outweighing the scientific, and trampling on the evidence. And I think there's been a lot of that the last 2 years.
Well, at the beginning of this, in 2020, all of our state and territory premiers actually listened to their public health advice.
Mm,
And most states and territories did extremely well.
yeah.
And now, of course, they simply ignore it.
Yeah, it was bewildering when especially in Victoria, when we made that shift from we're taking this really seriously and we're listening to everything Brett Sutton says, and then suddenly and we're fine now, no more restrictions. It's like I don't think we are fine. The numbers don't look fine.
No, they're not fine. And what's happening now is you're getting approximately 10% of all people who get infected ended up with long-term health problems.
Yeah, that's
Um,
that's
in
what
the UK,
scares me.
in the UK, 2.7% of the whole population have now got long COVID. I was
It's a
chatting with a
lot.
very well-known GP in Adelaide, doing a podcast just 2 or 3 days ago, and he was saying that 10% of his time now is taken up with looking after patients with long-term health problems
Oh,
from COVID. And that's now. Can you imagine what it's like in a year's time? We're getting this tsunami of people with long-term health problems. So, in Adelaide, for example, we're getting 5,000 cases a day. That's 500 people going to end up with long-term health problems.
Crumbs.
That's not good. Can you imagine how it's going to hit our health services?
Yeah, that's a monster. I did read the other day that after the 1918 pandemic, there was a massive increase in autoimmune diseases, and I know there's been some evidence of I know an increase in diabetes post COVID infection, even when the infection's been mild. I do.
Yeah, so a lot of it's thought to be inflammatory response.
Right.
But the thing is that what we know is that almost all viral infections can end up with some long-term health problems, including influenza.
Yeah.
The trouble is that we don't measure it. Uh, if you don't measure it, then it doesn't exist, does it?
Yeah.
Um,
We're back to data again, aren't we?
yeah, so a lot of the people who got chronic fatigue syndrome, when you actually question them, it turns out they had a viral infection a few months before.
Yeah. Yeah.
So this is not uncommon. It's just much more widespread. The sorts of things you can get once you've been infected include things like brain shrinkage, heart problems, blood clotting, nerve issues, severe headaches, and the list just goes on. And in many cases, people can't work anymore.
Yeah.
They're just too, they're too tired. They don't have the wherewithal to work anymore. And this is what we've got coming, in the future for us. And here's the government saying that cases don't matter anymore. It doesn't matter how many cases we get. It's irrelevant. Well, it does matter, unfortunately, for the poor souls that get infected and end up with long-term health problems.
Yeah. Yeah, and the potential impact on us as a society as well as on the individuals is catastrophic with those kinds of numbers. Does the vaccine make any difference that we've detected in long term?
Yes, absolutely. People who are vaccinated are far less likely to get long COVID.
That's good news.
It's very good news.
Well, thank you so much. This has been a really wonderful chat, and I'm excited to have this go out as my first episode of Make Me Data Literate. Thanks so much for your time. I really appreciate it.
It's been an absolute pleasure. Lovely to meet you.
Good to meet you too. Thanks for listening to Make Me Data Literate. You can support the work of the Australian Data Science Education Institute at givenow.com.au/ADSEI. Tune in next time for more conversations with amazing data experts.